Thank you, Keith. It is nice to meet everybody um, in a weird way, an anticipated way for sure. And I'm actually really happy to have this opportunity to share some of my observations that I've had in my 8 months on the job. I'm just now getting the opportunity to tell you about a little bit about myself. You can see up there, I've been a nurse a very long time. I've got a lot of NP experience also, at least half of my nursing career. I was in the medical observation unit, part of the ED, so very versed in these initiatives, and also I was in thoracic surgery for 5 years. And then when I was a nurse manager, I also had quality initiatives experience too, so I have a lot of experience to bring to this job, so I'm pretty excited to share that with everybody. So I'm going to actually be going over two different overviews of the modules. First one will be chest pain, and then I'll do the pediatric asthma. Those were the new ones that we rolled out last November. So it's kind of been coinciding with when I started. So I have a lot of invested in these, and then hopefully at some other opportunity I'll be able to share observations for the head injury and the PE. But for now, I've been doing what we're calling the SNAP reviews. It's basically the audits that are done as part of the P4P. And they're actually, we call them SNAP reviews because I don't like the word audit, and it stands for Sharing Knowledge and Perspectives. It's all about teaching and working with the abstractors to get the most out of all the abstractions and have the most accurate information and to really raise the level of how we're abstracting. So just a very brief overview on the chest pain module itself. We do have 9 module questions that are built around the heart plus T, or the heart score. We do only do a sample of 60 chest pain cases per month because of such a broad number of chest pain cases that come in. We had to narrow it down to 60. Those are sampled cases. And of course, this measure only addresses when it's appropriately to discharge a low-risk chest pain patient from the ED. And I'll show you examples of the questions that we're having, and it really follows the heart score. We do look at the history, the risk factors, the troponins, and the EKGs are all manually abstracted. The age is collected electronically and pre-populated. And so based on the above, even though we ask you later in the ED visit or in the module itself what if you've calculated a heart score, the module itself also calculates a heart score based on what we're inputting into the module itself. So here is a reminder of kind of what this is based off of. And what I'll be pointing out to everybody in a little while in my observations, there is very specific numbers. When we're looking at history, EKG, age, the risk factors, and troponins, they all have a calculated score. You can go to MD-Calc, you can put these calculations in, you can put your risk, and you will get an actual number. That's going to be important in a little bit. So here is a sample of our actual module questions. So on question 1, we are looking at all those risk factors that go into that. Of course, BMI, smoking, first-degree relatives, that's also going to be mentioned in a little bit. These are all important aspects, and we're combing the chart. And we do realize that a lot of times the ED visit does not always automatically bring forward some of this past medical history. So the abstractors are trained to go search in the chart. So anything that's not in the ED, if we have suspicion on it, we're going to go look for it and trying to verify it. For the second question there, we're looking at the characteristics of what brought them in, because we're looking at their suspicion of how high we think their level is of having a heart issue now. So those are all very specific questions, and again, we can find those in the nursing notes, the EMS notes. Your notes, of course, are most important, so we can look everywhere that's applicable for these. For number 3, that is looking at the EKG's interpretation. So we're looking at the EKG itself, but also very importantly in your MDM is your interpretation of that. We collect all the elements because, again, as a reminder, in the module itself, based on how we're answering these questions, it also calculates a heart score in the module. So as I've been doing these SNAP reviews, there's been a number of things that I've noticed in the documentation and in the charting. And one of the main things is that an actual heart score itself is missing. So some facilities are pretty good about putting a heart score in, and some facilities could probably do a little bit better. What I've also seen is some heart scores are given as a low, moderate, or high risk. They're just telling me a range, or it's below 4. That's not good enough for what I need. I need it to be an actual number because it is calculated as a number, so that is my expectation from all of you also. And then the family history. That is one of our risk factors, and it's very frequent that I'll see right in there that'll say, well, father has heart disease. There's no age. So I have no indication if it's an early onset or if it's going to comply with our family history or not. The EKG interpretations, those themselves are either not mentioned, or if they are mentioned, it's just, there's no mention of it other than this, like not worrisome or not intended, which tells us a little bit, that you're not worried about ACS, but it's still kind of like what Dr. Klein had mentioned. If you're not talking about it, we can't read your minds. The abstractors have to go with only what's documented. So certain things we can infer. And me as a clinician, I kind of know where you're going, but the abstractors need a little bit more concrete information from you. So we do include, as I mentioned previously, all the nursing and EMS notes for chest pain characteristics. We can look in a lot of places in the charts, but to do more efficient, and quicker, not that we need to be fast in our module abstractions, but the more you have in your whole history and physical when they come in, then the less places we have to go searching for all this other data. And we also look at the intended disposition from the ED visit. So I do notice a lot of times in that MDM, it'll be pretty sparse and the patient is discharged home, but I didn't see your decision making as to what made you feel comfortable to do that. So I'd like to see a little bit more of that. And then if you have any questions about that, we'll just if anybody has questions for me, we'll do it at the end of this part of it. So here we're going to transition over to the asthma module. This is an expanded version of the chest X-ray respiratory module. We have a sampled of 50 asthma cases and 35 bronchiolitis cases per month. The safe discharge measure is to identify when it's appropriate to safely discharge an asthma patient from the ED. There's 18 module questions that focus on the patient's symptoms and their history, what brought them in, what did they do at home, any meds given during the ED visit. We have a whole huge section that includes the medications given and ones that are discharged, and whether or not a chest X-ray was performed. So here's just a sampling of some of those questions, and these are the ones that I find can be a little bit more problematic for either the abstractors to find the information or just the way it's set up in the chart sometimes it's a little hard for them to discern and get this information. Believe it or not, the first one is, if there's a fever, that's usually pretty evident. What we don't know is that duration of fever. There are so many conflicting stories. We're just looking for anything within about the past 5 days. So any mention of the duration of a fever is much appreciated. We also need, if there's documentation that the patient was toxic, somnolent, lethargic, listless, or ill-appearing. Sometimes there's no mention of how the patient is actually looking. It just kind of goes right into the assessment. And then for what's question 4 on here, it lists those 7 entries or 8 entries of the actual physical exam. And we are talking about when you actually physically examine the patient, and we're looking for all of those particular elements. We actually ask that question for the first, second, and third. So we do that up to 3 times, which I'll have an observation on that in a little bit later. So question 5 is we're looking at the worsening clinical status in the ED despite treatment. So we're looking at all of those. So some of you are doing an amazing job, and you'll literally list out, we've gave 3 bronchodilators, we gave a steroid, this still isn't going on, we had to add high flow, we had to give MAG, we did these things, and we've got that, and we're easy to find it. But sometimes it's not so documented as well. So I'm just kind of asking you to be a little bit more mindful is when kids are not responding as well as we want them to, and we have to add in other interventions, we're trying to capture that, and I want you to be able to take credit for it, so document it. And then for the 6th one on there, we also do give you credit for any prior albuterol or bronchodilator that was given prior to arrival, because we know the decision is being made on giving those 3 bronchodilators and the steroids. So if it's already been given at home prior to arrival, we are acknowledging that, so we're not going to ding you for not doing that level of care. And then We're also asking for all the respiratory medications that are given, and we ask for up to 6 different respiratory meds, so the Duonebs, the albuterol, everything, and that is by route and dose, and it's very inclusive. Okay, so for my observations during these SNAP reviews, especially some of these poor kids, I know everybody's busy. The ED is a very busy place, but there is still scarcity of documentation in both the HPI and the MDM. And prior hospitalizations or intubation is not always noted. And so I've been training the abstractors to go back and look in the encounters if there's anything in your hospital system, anything that we can do. So it's just a hunt system. We have to hunt for these things if they're not actually noted, because I want them to verify if it happened or not. Of course, the duration of fever, as I mentioned before, is very difficult to determine. And then we also have, this is a bigger thing too. It's really challenging to determine the number of actual physical assessments actually performed. We're asking the abstractors to record 3 different ones, up to 3. Of course, you don't have to have 3. But it's really hard to determine what happened or how often. What I'm seeing a lot of times is like, a patient was monitored over time. Well, did you go in and physically assess that person? Did you put your stethoscope on them? I can't really tell. And honestly, we are using the attendings attestation also if they give a physical assessment in that attestation. So we're looking at all the determinants, everybody who's touched the ED people who have touched the patient, then we want to know about it. And then the review systems, that one has not been consistent with the HPI. I've been finding relatively decent HPIs, and then the review system is everything negative. So then I get the abstractors saying, well, they said this occurred in the HPI, but now when they reviewed all the system, they're saying none of this is going on. So it's just conflict of documentation. So for my overall last pieces of this, and this is what everybody knows, right? If it's not documented, it didn't happen. So I know all of you are doing amazing work, and I want that to be captured. So the more that you can put in a little bit here of a note or two or a click system or whatever we can do, I'd love to be able to capture that better. We do review all provider notes as well as the nursing notes, EMS notes, and we can, go back, phone call notes, anything that's going to be applicable to those particular module questions we're going to look at. When there is conflicting information, it does take us extra time to abstract these. The chest pain module itself has up to 45 data elements that they have to answer to, and the pediatric respiratory has up to 113 data elements. So they have to either nay or yay on every single one of those data elements. So they have to mark it off or try and find it and make sure if it's there or not. The actual average time to complete a chest pain module is about almost 9 minutes, and the average time to complete the pediatric respiratory one is a little over 15 minutes. So part of my focus has been trying to help the abstractors efficiently move through the charts and how to find all that data. So we're working on that on our end, but as much information as you can put in that initial history and physical, that would be fabulous. And we do have the abstractors expected to abstract at least 28 cases per day, but if they're doing a lot of hunting and pecking, sometimes it can take them 40 minutes just for one particular case. So, because my expectation is the highest level of veracity from all this information, and I'm expecting very high levels from them to find all this information. So it's important that we all work together on getting that. So any questions? Excellent.